Can a normal cell pretend to be cancer? Can a pap smear result lead us down the wrong path? In gynecological cytology, what we see under the microscope can be deceptive. A benign change might look malignant, and a serious lesion might be missed entirely. Sometimes what appears to be a harmless, benign cellular change under the microscope can closely mimic a malignant process, raising unnecessary alarms. On the other hand, truly dangerous lesions may be subtle and easily overlooked, escaping detection entirely. In this video, we'll explore the common entities pitfalls in gynecological cytology and pap test. Certain normal or reactive changes, like atrophy, tubal metaplasia, or post-radiation effects, can closely resemble serious conditions such as high SIL or adenocarcinoma. That's why understanding cytologic mimics and diagnostic pitfalls is essential to avoid misinterpretation. Let's start with atrophy. Atrophy in cervical cytology is a common finding, especially in postmenopausal and postpartum women. It results from decreased estrogen and progesterone, which leads to thinning of the squamous epithelium and a loss of normal cell maturation. Normally, squamous cells mature as they move toward the surface. But in atrophy, this process is disrupted. The smear is dominated by basal, parabasal, or deep intermediate cells, while superficial cells are often absent. Cytologically, atrophic cells appear small with a moderate to high nuclear to cytoplasmic ratio. They may appear singly or in syncytial, monolayered clusters. The nuclei are oval, uniform, with smooth borders, fine chromatin, and no nucleoli. Although benign, atrophic cells can sometimes resemble atypical squamous cells or even high SIL, due to mild nuclear enlargement and hyperchromasia, leading to possible false positives. So, how can we tell the difference? In atrophy, nuclear polarity is preserved, the nuclei are aligned and orderly. Chromatin is fine and evenly distributed, and the nuclear borders are smooth. In contrast, high SIL shows disorganized nuclear polarity, coarse chromatin, and irregular or indented nuclear borders. Recognizing these distinctions is critical. Misinterpreting atrophic changes can lead to overdiagnosis or unnecessary interventions. Next is irradiation. Radiation therapy is commonly used to treat cervical cancer. It works by delivering high-energy ionizing radiation, like X-rays, to destroy cancer cells in the cervix and surrounding tissues. However, this treatment does not only affect cancer cells. It also impacts nearby normal epithelial cells, leading to a range of tissue and cellular changes that are often visible in pap smear samples. These radiation-induced changes are reactive or degenerative, not cancerous, but they can easily mimic malignancy if not properly recognized. Let's look at the comparison. First, the nucleus. Irradiation cells typically show only a 1x nuclear enlargement, with a normal nucleus to cytoplasm ratio. In contrast, malignant cells often have 3x nuclear enlargement and a markedly high N/C ratio. Next, the chromatin pattern. Radiation changes show smooth, evenly distributed chromatin, whereas malignant cells display coarse and irregular chromatin. For the cytoplasm, irradiation cells usually have a pale or amphiphilic appearance, while malignant cells may have a bizarre or irregular shape. Another critical clue is the background. Malignant smears often have what is called tumor diathesis, a dirty background filled with red and white blood cells, necrotic debris, and inflammation. This feature is typically absent in radiation-related changes. Finally, it is essential to review the patient's clinical history. Knowing when a patient received radiation therapy can help interpret these changes accurately. Next, hyperchromatic crowded groups, or HCGs, are tightly packed clusters of epithelial cells with dark staining, hyperchromatic nuclei. These clusters often form three-dimensional patterns, which can easily be mistaken for abnormal or malignant lesions on a pap smear. HCGs are a major diagnostic pitfall. They can closely mimic high-grade squamous intraepithelial lesions, or even glandular abnormalities like adenocarcinoma in situ. But not all HCGs are malignant. Benign conditions such as squamous metaplasia, atrophy, reactive endocervical cells, tubal metaplasia, and lower uterine segment endometrium can also form similar-looking clusters. So how do we tell them apart? In benign HCGs, nuclear polarity is usually preserved, the chromatin appears fine and evenly distributed. The cells often form flat sheets, glandular, or tubular arrangements. In contrast, malignant HCGs show disturbed polarity, coarse and irregular chromatin, syncytial or palisaded clusters. Nucleoli are usually absent. One common pitfall is mistaking squamous metaplasia for high SIL, especially in liquid-based cytology. Both may appear as small, hyperchromatic crowded cells with a high N/C ratio. But the key differences lie in the nuclear details. Squamous metaplasia usually maintains nuclear polarity and shows smooth chromatin, while high SIL shows disorganized nuclei with coarse chromatin. Because these differences are subtle, focusing only on nuclear darkness or crowding can lead to overdiagnosis. Careful evaluation of nuclear details and cell architecture is crucial. Now let's talk about the cytological effects of intrauterine devices, or IUDs. IUDs are widely used for contraception, but their long-term presence in the uterus can trigger reactive changes in the endometrium and endocervical lining. These changes are not malignant, but under the microscope, they can look suspicious and challenging to interpret. In glandular cells, we may observe cytoplasmic vacuolization, nuclear enlargement with slight pleomorphism, prominent nucleoli, and even multinucleation. These reactive features can closely resemble high SIL, making it essential to recognize the differences. In high SIL, the nuclei are enlarged about 4 to 5 times the normal size. In IUD-related atypia, nuclear enlargement is also present, but typically around 3 to 4 times, slightly less than in high SIL. Both high SIL and IUD-related atypia show scant cytoplasm, contributing to a high nuclear to cytoplasmic ratio. The chromatin in high SIL is usually coarse and irregular, and IUD-related atypia can show coarse chromatin as well, making it tricky to distinguish. Nuclei in high SIL are often hyperchromatic and have irregular borders, sometimes with visible nuclear grooves. Similarly, IUD-related atypia may also show hyperchromatic nuclei, though grooves may be less prominent. However, the key distinguishing feature is the presence of cytoplasmic vacuolization, which is common in IUD-related changes but not seen in high SIL. This vacuolization suggests a benign, reactive process caused by irritation from the device, rather than a true high-grade lesion. Moving on, tubal metaplasia is a protective change that often occurs in response to chronic inflammation in the cervix. When the cervical lining is repeatedly damaged, the body adapts by transforming the cells into a tougher type, resembling fallopian tube cells with cilia. These ciliated cells help clear mucus, debris, and germs from the area. This happens because both the cervix and fallopian tubes come from the same embryologic origin, the Müllerian duct, making the switch to fallopian-like cells a natural defense mechanism. Let's look at the characteristics of tubal metaplasia. The cells typically show a high nuclear to cytoplasmic ratio, with scanty cytoplasm. The nuclei are often oval or elongated, hyperchromatic, and contain fine chromatin with inconspicuous nucleoli. A defining feature is the presence of a ciliated border and a terminal plate, which indicates differentiation toward fallopian tube epithelium. Tubal metaplasia can mimic serious pathologies such as adenocarcinoma in situ and high-grade squamous intraepithelial lesion. It can present in solid clusters, polysadding patterns, or rosette formations, architectural features that are strikingly similar to malignant cells. Combined with enlarged hyperchromatic nuclei and a high N/C ratio, this resemblance may lead to false positive diagnoses. Let's compare tubal metaplasia with adenocarcinoma in situ, or ICE. Tubal metaplasia typically appears as stripes of large cells, while ICE forms feathered clusters. Cilia and terminal bars are present in tubal metaplasia, but completely absent in ICE, making them key distinguishing features. Nuclear polarity is preserved in tubal metaplasia, with cells aligned in an orderly fashion. In ICE, it's disorganized. The chromatin in tubal metaplasia is fine and evenly distributed, while ice shows coarse, granular chromatin. And finally, nucleoli in tubal metaplasia are inconspicuous, whereas in ice, they are absent altogether. Lastly, reparative cellular changes are a reactive response to inflammation or damage in the squamous or glandular epithelium. They're commonly triggered by infections, physical trauma, or cervical procedures. While these changes are benign, they can mimic malignant adenocarcinoma on a Pap smear, leading to false positives, because they share features like enlarged nuclei, prominent nucleoli, and disrupted architecture. To avoid misinterpretation, we focus on three key differences: the degree of nuclear enlargement, cytoplasm, and cell arrangement. One key distinction between reparative cells and adenocarcinoma lies in cellular arrangement. Reparative cells appear in flat sheets with streaming, while adenocarcinoma forms three-dimensional clusters, reflecting disordered growth. Cytoplasm helps too. Reparative cells have abundant cytoplasm, while malignant cells show scanty and dense cytoplasm. In terms of nuclear size, reparative nuclei are enlarged about 1 to 2 times, compared to up to 3 times in adenocarcinoma. Chromatin texture also differs, smooth and vesicular in repair, but coarsely clumped in malignancy. Additional signs of adenocarcinoma include nuclear pleomorphism, knobby contours, and a proteinaceous background. To conclude, relying on limited features, like nuclear size or darkness alone, can lead to misdiagnosis. Instead, we must carefully evaluate multiple aspects of the cell: nuclear polarity, chromatin texture, cell architecture, and most importantly, the clinical context. Being aware of these common pitfalls helps reduce misinterpretation, avoids unnecessary procedures, and ultimately improves patient care.